Hello everyone and welcome back, bang on time, 10:15 for the live stream COVID-19 Respiratory Update Session. Now we're moving on to practicalities, so I'm delighted to be joined by Tash and Jane. Tash is going to go first to go through respiratory assessment, what is normal and what is the effects of COVID-19. So this is designed to be really basic, a really basic overview, and we'll also identify things that you might need to practice practically or just something that you might need to go away and have a look at. But again, designed for everyone, and hopefully we can ask some questions as well at the end. So over to you, Tash, who's a wonderful respiratory physio, and she's based here in Greenwich in London. So thanks, Tash.
Thank you, Rachel. So as Rachel said, my name's Tash, my name's Natasha. I am a respiratory physio. I have worked over in ITU, HDU, the wards, and in the community as well. So hopefully I can give you a little bit of an overview on respiratory assessments and what you need to be looking out for with our patients. So here are my details. There's a lot to cover, so hopefully there'll be time for questions and things at the end, but if you want to reach out to me afterwards, then that's absolutely fine. So you can email me or you can tweet me as well. So that's all good. Okay, so what I hope to cover, so I'll just like to give a basic overview of a respiratory assessment, so what to ask and what to do, and hopefully be mentioning potential COVID scenarios as I'm chatting through everything as well. So just briefly going over the importance of a respiratory assessment. So a thorough respiratory assessment ensures that all the necessary information is obtained so the correct treatment is implemented for our patients. So as autonomous practitioners and therapists, it's especially important to have the skills to assess and reassess our patients so we can adapt and manage our patients accordingly. So getting straight stuck in with a subjective assessment. So this allows us therapists to gain an understanding of how our patients are feeling, their journey through their acute illness, a history of their health, their function, and their social circumstances prior to their admission. So the subjective assessment allows patients also to express their symptoms from their own viewpoint and help guide the objective assessment and plan a treatment program with the patient's needs at the forefront, which I think is a really lovely definition, which I stole from Physiopedia, thank you. And this will need adapting with different patients and different circumstances, and I'll explain a little bit more about that later. So in terms of history of present condition, so I just need to pull up my notes. So looking into diagnosis, so a typical respiratory inpatient may have a diagnosis of an infection exacerbation of COPD or a hospital-acquired pneumonia following, say, like a big colorectal surgery. But let's stick with our COVID theme. So I would want to know when they tested positive, did the respiratory symptoms come on gradually or suddenly? The duration, sorry. So, how long have they been unwell for? How long have they been in hospital for? Has their condition deteriorated or improved over time? Their severity, so have they been relatively stable on the ward with minimal oxygen, for example, or have they been ventilated on ITU with multi-organ failure? If they are ventilated, it would be useful to know their weaning progress so far. Have they been a slow, long wean, or are they actually coping quite well with being weaned off a ventilator? Also, the effect on their mobility and activities of daily life. So we can compare what they're doing now to how they were before. And also any previous treatment and efficacy. So this could be any medication that the doctors have started, or it could be any treatments that we've implemented. So if they're having intermittent positive pressure breathing, is this working quite well, or do we need to think about adapting that treatment? So with past medical history, be looking to see if they've had any thoracic, nasal, pharyngeal, tracheal trauma or surgery, or hospitalisation for any pulmonary disorders. With our respiratory patients, I think we're especially looking to see if they have pre-existing respiratory conditions. So do they have COVID, but do they also have asthma? Do they also have COPD, bronchiectasis, cystic fibrosis, or interstitial lung disease? If they do have a respiratory condition, do they have any home oxygen or home NIV or CPAP? And also worthwhile noting if they have any other medical conditions, so any cardiac problems, hypertension, diabetes, cancer, or ongoing MSK issues, which we may, run into when we're mobilising patients. So, moving on to social history. So this is probably more important when you're planning discharges, and I know Kath Edwards is going to discuss this more this afternoon. But as a respiratory physio, I would be kind of thinking, okay, well, do they have a smoking history? There's a chance that they could have an underlying lung disease underneath their COVID diagnosis, so that could raise a few questions there. We need to know their previous mobility and function before their admission. I tend to use the MMRC score for this, which is quite a good outcome measure, scoring on 0 to 5, from absolutely not breathless at all to so breathless that they can't leave the house or really struggle to get washed and dressed themselves. We are also wanting to know their home environment, so again, later on in the discharge planning stage, do they have stairs, bathroom downstairs, what support system and carers they have. I think it's worth noting that in these crazy COVID times, that patient support systems may have shrunk considerably. So where they might have had a whole system where one daughter does this and one son does that and the grandkids do this and that, they might just have one person as a support bubble, and chances are that if they're unwell with COVID, then they may be unwell with COVID too. So they're things that you kind of need to think about when looking at a social history for your patients. Also, employment and economic conditions. I've mentioned here quickly that, yellow flags, and psychosocial issues we need to think about when assessing our patients, especially in these crazy COVID times. Their employment status may have been affected. There's more pressure on, if one person is working, one person is sick in hospital, they're trying to, get money into the household whilst homeschooling children. So it can get, very complex. So it's always worth bearing in mind that, our patients potentially have a lot going on, and this can all affect their breathing if they're very anxious, and it can affect their recovery as well. So moving on to drug history. So we need to know what medications patients are on, what oxygen they're on, what flow rate. With a respiratory hat on, we need to know if they're on any nebulizers. So for example, salbutamol and ipratropium are our main bronchodilators that we might see, which help to open up the airways. Saline nebulizers as well, that can help to loosen up phlegm. Worth noting if they're on any antibiotics or steroids, mucolytics like carbamazepine, which can also help to loosen up the phlegm, and if they're on any long-standing inhalers, so if they are COPD and asthma, if they're on long-standing inhalers from before their COVID admission, and also just making sure that they are still keeping up to date with their regular inhalers, because that can affect their breathing if they're not, say, taking their normal inhaled steroid that they've been taking for the last decade. And then getting a bit more into the nitty-gritty is their present condition. So how is the patient doing right now? So this is assuming that the patient is not ventilated and communicate their symptoms. But for our ventilated patients, this information can be gained by our lovely ITU nurses that are caring for them. So we'll be looking at breathlessness at rest, their current exercise tolerance, and comparing that to what their exercise tolerance was before they became unwell. So that's really important. So say, for example, I keep mentioning a COPD COVID patient because that's what I generally see. So if we have a COPD COVID patient who reports that they're struggling to walk to the bathroom on the ward, you know, that can raise some issues. However, you know, that may be their baseline. You know, they're struggling to walk to the bathroom in their own house for the last few years, then that's not necessarily a huge worry. Whereas I'd be more worried about, you know, the younger COVID patient who's previously independent, running marathons, and now, you know, they're saying that they can't really mobilize very far on the ward. So it's really important to compare current exercise tolerance to their pre-COVID exercise tolerance. We want to ask them about their cough. Is it dry? Is it productive? Their sputum, is it easy or difficult to expectorate? And if they are expectorating, how much? Their sputum colour as well. So viral infections often produce clear white sputum, and bacterial infections often produce yellowy green sputum. So COVID is a virus, so we know this, and so chances are they are producing sort of a bit of white sputum, if at all, because some pneumonia are not particularly productive. But we also need to think that, you know, they are at risk of also getting another infection on top. You know, so if we think about it, they are, you know, a hospitalized patient, you know, they're already fighting a viral infection, especially if they're not mobilizing very much, they could easily pick up a bacterial chest infection. And as respiratory physios, we can often be the first person or the first clinician to suspect this, because we love talking about the color of phlegm. So just as a little quick summary on the subjective assessment. So, you know, this is all on the basis that we've never met the patient before. So just as a recap, you know, a thorough subjective assessment with a respiratory patient, say in the community or a clinic, can take a really long time. You know, to get all of that information can take a while. But in the hospital, we're really lucky because we've got the notes, and actually someone's probably asked a lot of those questions for us when they were being admitted. So a lot of this information can be found in the medical notes. You can gain a lot of information from your handover with the nursing staff or any physio colleagues that may have seen the patient before you. So for example, if you're working on a high dependency unit, you know, and meeting a patient for the first time, that patient, chances are one of your ITU physio colleagues have seen them, and they can give you a handover and just bring you all up to date with everything. So as I mentioned earlier, your subjective assessment will naturally adapt depending on the situation, depending on the patient, and you'll focus more on some areas, you know, more than others. So, you know, for example, if you're seeing a ventilated patient, you know, most of your information will come from the notes and from the nurse. Your COVID patients with pre-existing medical or pre-existing respiratory disease could raise more questions about their past medical history and their usual symptoms prior to COVID to picture a baseline. Patients approaching discharge, they will require more questions about their home environment and their support network, whereas you're acutely unwell patient with retained secretions, requiring an on-call physio call out at 2 a.m. You don't need to know too much about the social history. You can kind of just skim over that part in the notes because it's not particularly relevant to what you need to do right there and then. You're probably more focused on, their history of present condition. So what has happened, their present condition, i.e. what's happening right now, and their drug history. So, have they had a recent nebulizer? And then you want to move on to just physically checking the patient. So, so this is, what I've just gone through is very much, if you haven't met the patient for the first time and you're really trying to get a good history. But when you're on the ward, chances are that you will see the same patient day after day and you'll build up a relationship with them. And then in those situations, you will just pick up where you left off, and note any additions to the history of present condition, any changes to their present condition, or any medications. And then you will be ready to start your objective assessment. So following the subjective assessment, an objective assessment will complete the process and will give you the information you need on how to treat and manage your patient. So I would start off with your observation and the general appearance of your patient. So how does the patient look? Are they alert? Are they drowsy? How do they sound? And this can give us so much, this gives us so much information before we've even reached out for our stethoscope. So does the airway sound obstructed? Are they audibly crackly or wheezy? So we can start picking up lots of information before we've actually physically touched the patient. So what's their position? Are they slumped in the bed? Are they slumped in a chair? So this can affect their oxygen levels if they're in a poor position, and it can also affect what you hear on auscultation. So you may even think that they're sounding a little bit quiet on one side, but actually they're just slumped that way and probably need to be repositioned to get a better assessment. Another position is forward lean sitting, and this can indicate that they're working quite hard, they have increased work of breathing. I've mentioned here the body weight and the size of your patient, your BMI, and again, high BMI patients, we are seeing that a lot in our COVID population. That can affect their breathing too. If they've got a lot of weight on their diaphragm, that can cause breathlessness, and they could have been breathless before they had COVID, and it's all just exacerbated that now. And also we need to be thinking about risk assessments. We need to be looking after ourselves. We need to be looking after each other. So especially on ITU, if your patient is sedated, they are heavy. Even if they're not a big patient, sedated patients on ITU are heavy. So you need to do a quick risk assessment and see if, okay, maybe you need an extra pair of hands to assess and treat that patient. You could also look out for kyphosis and kyphoscoliosis, so curvatures of the spine. May not be easy to see if a patient is sat up in bed and surrounded by pillows, but you may notice this more on auscultation. And again, the curvatures of the spine can affect breathing as well. So cyanosis, so this is the bluish tinge that you can see, and it's normally a sign of hypoxemia. So checking for that, checking the colour of the patient. Important to note that with our COVID population, we are seeing our BAME patients as well. So I would say it's always really good practice to look at the tongue, because it may not, you don't want to miss cyanosis just because they've got a darker skin tone, whereas the tongue will be very, very obvious if the patient is cyanosed or not. looking at use of respiratory muscles, and this is a sign of increased work of breathing. So you may find that a lot of the shoulder girdle muscles are activated when people are breathing, patients are breathing, or you may even find it around the abdomen, especially on expiration, as patients are breathing out. If they're working quite hard, you can see their abdominal muscles clenching. And pursed lip breathing, very much the same, all a sign of increased work of breathing. So I'm just going to quickly touch on ventilated patients. I know Liam is going to discuss ventilation a little bit later this morning. So we're looking at the mode of ventilation. Are they fully ventilated or pressure support, CPAP? The route of ventilation, so is it via an endotracheal tube or a trachea, or are they being ventilated with NIV, non-invasive ventilation? Their level of consciousness. So with our ventilated patients, it may be that they are being lightened up, so their sedation is being weaned. No one really knows exactly how much sedated patients can hear or understand, so it's always really good practice to talk to the patient and explain what you're doing before you do anything with them. So I would always say to a ventilated patient, you know, I'm just going to listen to your chest, or we're just going to roll you over. You know, it's just always best practice to still talk to them as if they can hear and understand every word that you're saying. And again, going back to risk assessments, as I mentioned, with potentially heavy patients, for our ventilated patients, you need to look out for the multiple lines, drains, and catheters, and just be very, very careful. So a little top tip of mine, when I was working on ITU, I would almost think out loud when I was looking at all these attachments. So I would literally approach a patient's bed and say, like, okay, so I can see there's an outline there and the catheter is here, and you know, you've got IV fluids over there. And I think it just reassures the nursing staff as well, you know, that as the physio, we're not just going to come in like a wrecking ball and accidentally pull something out. But it's also just good, you know, from personal experience, it was also just good for me to know exactly where everything was. So when I am manoeuvring around a patient, you know, I was just being so careful not to pull on any lines or anything. Okay, so moving on to then our vital signs. So what we need to look at is their SpO2, so their saturation levels. So different patients have different target sats. So normal values, generally speaking, are around about 94 to 98%. If your patient is COPD, then they may or may not have target sats of 88 to 92. So these are for patients who are normally known to be a carbon dioxide retainer and tend to use their hypoxic drive for their respiratory function. But the National Institutes of Health has recommended that COVID patients have a target SATs of 92 to 96, which is helpful information for us respiratory physios if we're deciding whether a patient is stable or not, or if we're deciding whether we need to titrate oxygen up or down. Also really important to remember to note the oxygen flow rate or the fraction of inspired oxygen, because it's all relative. So patient A, who is saturating at 93% on room air, compared to patient B, who is saturating at 95% on 60% oxygen, patient A is your more stable patient. So it just is, it's all relative. We need to know the respiratory rate, so normal values of around about 12 to 16 breaths a minute. We need to look at their cardiovascular bits as well. So heart rate, as I said, normal values of 51 to 100, and blood pressure, normal value is 120/60. So when doing their vital signs, so whether you're on ITU and you're just looking at the monitor, which is all there, or you're on the main ward and you have to wheel over the obs kit, it's always good practice to check their obs chart, which is normally at the bottom of their bed. And it will just give you an overall picture and identify any trends in abnormal readings. And the obs chart also really perfectly highlights the abnormal readings. So, various, depending on what ward you're working on or what hospital you're in, most obs charts will kind of have like an amber zone or a red zone. So you kind of know how stable your patient is and if they are kind of heading off into a sticky situation and going in the wrong direction with their vital signs. So I'm very, very just quickly touched on arterial blood gases. This is a whole nother presentation in itself. So I've just listed the normal values here. So latest ABG results, they can be found in the OBS chart, or they could be documented in the medical notes. And these are the values that I use, but I know there can be some very slight variation depending on the hospital that you're in, but the variation is very, very slight. So all you need to know really is, if their blood gases are normal or abnormal. So in our respiratory patients, you're looking to see if they're in type 1 respiratory failure. So that's when the oxygen is low, the PO2 is low. They could be in type 2 respiratory failure, where the oxygen PO2 is low and the PCO2 is high. And also looking if they are compensating, and that will be reflected in the bicarb and the base excess. So this is just another tool that could be added, really. So just something else to look at. It's especially important if you're involved in managing patients on NIV. So sorry, I can't go into more detail just because I don't have the time. But as I said, give me, drop me a line if you want some more information on that. I have got loads of other presentations on analysing ABGs. So then moving on to auscultation. So I have just borrowed this from Physiopedia as well, just for those of you who feel a little bit rusty on auscultation. I know we've got some people who have logged in today who may have done a respiratory rotation years ago and are coming back to the wards, or if you're band 5 and you did your respiratory placement a while ago. So this kind of just describes where you need to be placing your stethoscope. There are so many more resources out there online, so I feel like I haven't really done you justice just by sticking this on here, but this is where you need to go. So I'm just going to quickly flick over that and you can come back to that at a later date. So I'd much rather talk more about when you're auscultating, what you're listening out for. So you're listening out for your breath sounds, so your normal vestibular breath sounds versus your bronchial breath sounds or diminished breath sounds. And this can be heard over consolidation. And sometimes you might even not hear anything at all, and that may be an area of collapse, for example, pneumothorax. You're also listening out for added sounds, so mainly your crackles. So your coarse crackles can normally indicate sputum or infection. Your fine crackles may indicate more sort of fluid, so pulmonary edema, or it could also be the sound of scar tissues that you get in fibrosis patients. You may also listen out for your wheezing, mostly on expiration. So a low tone can actually indicate that there is sputum, and a high tone can indicate that there's bronchospasm. So really knowing and shutting down of the airways. So I've put here in bold to search auscultation and lung sounds on YouTube to listen to examples. So I wanted to play a video, but I was worried that everything would just crash and I'd lose everybody. But there is, as I said earlier, there's so much information out there, way more than when I was a student or a band 5, on the types of things that you'll be hearing in auscultation. If you're feeling a little bit out of practice, I really strongly recommend that you go back and have a little look at some of these videos that are on YouTube, because they're really, really great. So go back to our COVID patient in pneumonia, COVID pneumonia. You may hear diminished breath sounds, you may hear bronchial breath sounds, you may hear crackles in that affected area, and that's all very typical with consolidation that you get with any pneumonia, whether it's COVID community acquired, hospital acquired. So I'm just going to very quickly touch on the AtoE assessment. So as physios, we tend to think as in SOAP notes. So we do our subjective and we do our objective, and that's what I've talked about today. But the AtoE assessment is often what medics use, and that's what you might see in the notes. So they use this system. So just as a quick overview, so they look at the airway, whether it's patent, is it occluded, obstructed, is the patient self-ventilated? If not, what mode of ventilation are they using? So again, we cover that in our objective assessment. They then move on to B for breathing, which is the respiratory rate, the work of breathing, their SATs, their ABGs, their chest X-ray, which I think has already been covered, auscultation, cough, sputum. Again, we cover the same thing in our objective assessment. C is for circulation, so they'll look at the heart rate, the blood pressure, the skin colour, and the urine output. D is for disability, so the level of consciousness. So they will often document whether the patient is alert, or if they're responsive to voice, responsive to pain, or unresponsive, and if they're sedated. And E is for exposure, so they're looking for injuries, surgical wounds, any drains, or any attachments. So I just thought I'd mention this just because you might see it in the notes when you're working on the wards, especially on ITU and HDU. But as I said, generally speaking, as physios, we tend to use our SOAP notes, and we don't necessarily, even though we gather the same information, we may not document it this way. It's always good to be able to present information this way, so if you're worried about a particular patient and you want a doctor to review them, then it might be worth presenting the information in this order, just because it's what they're used to, and it's something that they can understand and identify with quite quickly. So I know I'm running out of time, and I'm so sorry, Rachel. So I'm wrapping up, I promise. So I would just to quickly cover reassessments. So we've done our subjective assessment, we've done our objective assessment, but we always reassess patients. We always reassess patients after treatment, and this is so we can analyse if the treatment was effective, so we can make a plan. But we naturally reassess patients during treatment as well, and that's a very natural process. So every time we look at the obs monitor on ITU, or every time we check their SATs on the pulse oximeter on their finger, or every time that we just ask the patient, you feeling okay, in between, say, sets of intermittent positive pressure breathing, we are constantly monitoring, reviewing, and reassessing our patients. We're reassessing the situation constantly. So the respiratory assessment isn't just before and after treatment, it's a much more fluid process. So in conclusion, I feel like I've just non-stop throwing so much information, so I'm really sorry. It's so much to cover in such a short amount of time. So in conclusion, so we have our subjective assessments, so our history of present condition, past medical history, social history, drug history, and their present condition. So we're using multiple sources of information. So this could be from the patient, the medical notes, the nursing staff, our physio colleagues, and we mentioned that, just to remove this so I can see, that we can focus on areas which are relevant to the patient at that time of their assessment. So our objective assessment mainly focuses on observation, vital signs and auscultation. And respiratory assessment of COVID-19 patients, in my experience, not that much different to your run-of-the-mill respiratory patient who, as I said, may have come in with, COPD exacerbation, or if they've developed a chest infection whilst being admitted for something else. We're still looking for the same information. We're still trying to get to, still trying to figure out what their symptoms are. At the end of the day, we treat their symptoms, we don't treat a condition. And COVID patients, they can have different symptoms. So, you know, a COVID patient could be unproductive, another COVID patient could be very, very chesty. So we would treat their symptoms rather than saying, you know, these are COVID patients, this is what we do for a COVID patient, You know, that's the whole point why we're talking about this assessment. You know, we need to figure out what that particular patient is experiencing so we can treat their particular problems. So it's not hugely different. So these assessment techniques that you would have learned as a student or on your band 5 rotations, you know, it's the same stuff. So you've already got all the tools you need to manage these patients. So if you're nervous about managing these COVID patients, don't be, because it's the same. It's all very routine respiratory assessment things that you would have learned in the past. And just to look after yourselves, you know, and look after each other and stay safe out there on the wards. I know it's a bit crazy out there. So you're all doing really, really well. For those of you who are working on the wards, for those of you who are being redeployed back to the wards, you know, you're doing an amazing job. And yeah, that's all I have to say.
Thank you so much, Tash. Really, really great. Now, there is lots of questions in the chat, but I'm actually just getting through them.
Oh gosh, okay.
So you've I think everyone really enjoyed that. So I am just going to keep going in the chat with the questions and invite Jane to come on.
Yeah, okay.
So if you could just stop sharing your screen, that would be fantastic.
Yeah, I will do. So let's stop share.
Now, you are more than welcome to stay on for this session, or you can leave and just enter the chat box. It's entirely up to you. So, Jane, can I welcome you to do the next presentation?
You can.
Now, Jane is an amazing respiratory physio, another amazing respiratory physio that I worked with initially in London, and now Jane is in the West Midlands somewhere. I can never quite remember where. Worcestershire. Thanks for that. Okay, Jane, and I'm just going to let you introduce yourself and talk all things oxygen.
Thank you, Rachel, for inviting me to talk today about oxygen. So as she said, my name's Jane and I'm the respiratory matron at Worcestershire Acute Hospitals NHS Trust. And that means that I look after our community home CPD team, our home oxygen service, and also the respiratory nurse specialists that are based at both our Alexandra and Worcestershire Hospital sites as well. So today's topic is going through about oxygen delivery devices, and why it's really important is that oxygen's a drug, and however much in hospitals we see lots of patients on oxygen, it's really important that we know why they're on oxygen and actually what device they're on and why it's important to keep them as they are or wean them.
Jane, if possible, could you go into presentation mode? Would that be all
sorry,
right?
it was meant to have gone.
Sometimes it doesn't.
Here's to frozen right there.
If not, don't worry, because we can see the slides perfectly.
Right there.
I don't want to mess it up.
Can I stop sharing a minute and go back in?
Of course you can. It's because you've been waiting patiently in the background for so long.
It's all right.
Perfect. Thank you.
Right. So the rationale for oxygen use. So really, the aim of the oxygen we're giving to patients, be it the breathing air or breathing supplemental oxygen, is to actually maintain adequate oxygenation while minimising the work to the cardiopulmonary system to do this. Okay. So again, basically, we need to know what normal is in order so we can treat the abnormal. So as Tash was saying, we're looking at saturation levels, and again, we're looking at SpO2, that's your saturation measured by a pulse oximeter of oxygen. And again, in normal healthy adults, we're looking at daytime saturations of between 96 and 98%. And again, looking at the COVID patients, they are looking slightly lower at 92 to 96%. But again, it's really knowing what is normal. Again, with patients who've got underlying lung disease, they may be allowing saturations of 88 to 92%. So again, knowing what your normal is for your patient is really important. Again, clinically objectives, why are we giving the oxygen? So again, we really want to correct documented or suspected hypoxemia. Again, if you're looking at blood gases, as Tash was talking about, you're looking at low PaO2s. And again, your SaO2 is different to your SpO2. And in fact, this is an arterial saturation level, hence the A rather than the P. And again, less than 90%. Again, there are going to be some acute care situations where we think that hypoxemia is only suspected. And they're going to be in things like severe trauma. So if you had massive blood loss, we're going to want to give people extra oxygen. During an acute MI, again, extra oxygen is really important to maintain that healthy heart function. And again, short-term therapy, so used most often in your post-anaesthesia recovery. So the patients who come out of theatre, who've been extubated, or again on ITU who've been extubated, may have a little bit of oxygen just to kind of keep them going while they're waking up and recovering properly. Now, there are lots of different ways to deliver oxygen. And again, I'm going to run through each one individually, looking at kind of what it does, how much oxygen you can get from each one, and the pros and cons really. And again, for lots of people, this may be quite simple, quite basic, but for those that have been out of the practice for a while or in outpatient situations, these could all be brand new, or trying to troll back through long histories of, oh yes, I remember using those one day. So again, we've got nasal cannula, simple face masks, non-rebreathe masks, trachea masks, looking at air entrainment masks, so often called Venturi valves or dials, and again looking at kind of high flow nasal oxygen therapy as well. So for most people, seeing somebody on nasal cannula isn't a new experience. In lots of hospitals, it appears to be a rite of passage. You come into hospital and you get given some nasal cannula and off you go. Again, they're indicated really for a low percentage of supplemental oxygen needs. So the flow rate is between 1 to 6 litres. Again, ideally, you want to be going as high as 5 or 6 litres because, again, the damage it can cause and the uncomfortableness. And again, what this does, it can deliver approximately 25 to 45% oxygen FiO2 wise. And how we estimate this, and it really is a true estimation. So really don't take this as gospel as to what they're getting. So approximately 1 litre of oxygen additionally will give you between 3 and 4% FiO2 in addition to the air we breathe of 21%. So as you can see, 1 litre will give you about 24%, 2 litres 28%, 3 litres 32%. But again, this is not absolute and will really depend as to how fast the patient's breathing. The faster the patient breathes, what happens is the more air they're drawing in, and what that air is doing is diluting the oxygen they're breathing in from the nasal cannula. So actually what they're receiving may be significantly reduced to what the dose you think you're giving them. So again, the pros of using nasal cannula is they're simple and they're reliable, and patients generally tolerate them quite well because, again, the important thing to a patient is that they can eat, they can talk, and they can drink. Again, the cons for using nasal specs is that they can become easily dislodged. And for lots of us, seeing patients who've either got one nasal prong in is quite common, or that they're not there at all. Again, pressure areas are really important to make sure that they're not breaking down, particularly behind the ears, as again, tendency is people pull them too tight and they break down around the backs of the ears. If your patient has got the beginnings of a pressure area behind their ears, then either using the padding that comes with them, or again, use a different device entirely, or a different style of holding the nasal specs to potentially behind the head may be better than going around the ears under the chin. Again, nasal trauma. Some patients, they don't tolerate them very well, particularly if they've got thin mucous membranes, so they can often be prone to kind of nosebleeds or kind of irritation there. So again, their tolerance and comfort levels are really important. Again, like I said, high flow rates delivered between 5 and 6 litres, although allowed, can be really quite painful and again not tolerated for long periods of time. Simple face mask. So again, probably used to give a slightly higher amount of oxygen than you would do for nasal specs. And again, the flow rate for these needs to be a bit higher. So on your wall dials, between 6 to 10 litres. And again, this will give an approximation of between 35 and 60%. Again, based on the estimation that you're adding your 3 to 4% for each litre that you give to the dial. Again, most typically seen in your post-anaesthetic scenarios. Okay, but again, you will often find in wall cupboards, they've got a whole box of these simple face masks, so that when you ask, have you got an oxygen face mask, this is the one that they'll come out with, and it may not be the one that you're expecting. So again, making sure that if you're asking the patient or the nurse staff or member of staff to go get some oxygen for you, that you know what's coming out the box. Again, why they're good is that they're simple, they're easy to apply. Just go use the elastics over your head and tighten them up as needed to keep them in place. Again, can be good for mouth breathers, so patients who keep their mouth open all the time, so you may find that they're not breathing in particularly through their nose. So, but what the risk of these is that you do need to keep the oxygen dialed up to at least over 5 litres, or there's a risk of kind of the carbon dioxide rebreathing in the mask because you've not got the clear out flow pushing it out through the valves. So again, if your patient is beginning to kind of wean down their oxygen and is getting below 5 litres, you want to be thinking of a different device for oxygen delivery, be it nasal specs, or if you want more controlled oxygen, go on to a Venturi valve in particular cycles. So I think probably during our COVID patients, we'll begin to see a lot more non-rebreathe masks, particularly amongst those patients who are deteriorating. And again, they may be patients who are for escalation to HDUs or respiratory units if they aren't there already, or for ITU. But it may also be where our patients will max out and this is their ceiling of care for the giving of oxygen. Again, it's used particularly often you'll see them during resuscitation rounds and on crash trolleys, because again, it can deliver the most oxygen in a short burst. And what it is, it's a face mask that has a reservoir chamber. And what happens is the oxygen is piped in, and as long as you close the 2 valves in the face mask, the bag will open and extend, and that's the reservoir of oxygen. So when the patient begins to breathe, they're actually breathing in from the chamber to make sure they're washing out all that carbon dioxide and kind of getting that as much oxygen into the system as possible. And again, it's really important that again the flow rate is between your 10 to 15 litres in order to get the high amounts of oxygen that these patients are going to be requiring. So again, within the mask, there are 2 valves. If you have both valves on, you're going to get about 80%. If each valve comes off, it's worth about 10%. So again, you're going to get 90% if you take off one valve, and up to 100% if you've got both valves off. So again, it's making an idea of what the patient's on at the time. Because again, you may be thinking a patient's on 100%, but actually they're only getting about 80. So there is a bit of wiggle room. So patients who are neck breathers, so patients who've actually got a tracheostomy, or those patients who may have a stoma from laryngectomy, they're going to need a mask that goes over their neck. There's no good giving them oxygen through their face mask, their face is not going to be received. Again, the design of the mask means that you really can't really give dry oxygen. Again, you don't want to give these patients dry oxygen because again, by going through the neck, you've lost the natural mechanisms for humidification and warming of the air. Again, in normal breathing through the mouth and nose, you're humidifying the air through the nose and again, warming up to body temperature, which is making it less work for the body to actually carry on. If you just put in cold air and cold dry air particularly into the neck, the body's got to work a lot harder. And again, what that's going to then do is if these patients have got secretions, it's going to dry out these secretions rapidly. Now for some patients, obviously transferring between wards and bed spaces, they're going to need to use dry air at this point. But again, once they're in their bed space, really important to try and convince them onto a humidified circuit if at all possible. Air entrainment devices, which are very long term, but again, typically they're known as Venturi valves. So what's happening is the oxygen is coming in from the wall, as you can see, and through the ports on the valve itself, air is being entrained. Now, unlike the simple face mask, which also allows air in, it's got no control. The Venturi valves are controlled so that you'll know precisely how much air is coming in and oxygen is coming to get the right mix, that you know precisely how much your patient's getting. These are particularly important if you've got patients who've got known respiratory failure, who are temperamental with oxygen. So maybe your COPD patients who are on NIV at home normally, or on NIV at the moment because of respiratory failure. Again, potentially some of your neuromuscular patients who again are a bit temperamental with their oxygen may find that giving them controlled oxygen through a Venturi valve is much better. So these are your full selection of Venturi valves that you're going to find hopefully in your respiratory wall cupboards. And again, they go up from your 24% all the way up to 60%. And again, conveniently and helpfully for anybody who's using them, it tells you how much oxygen is going to be given and what the minimum literage per minute needs to run out at the wall. So in order to get your 24%, you need to run at least 2 litres a minute. 28 is 4 litres as it goes up. And what you can see from the pictures is obviously in the low percentage oxygen, the amount of air being entrained is quite high. Okay, and going across towards the left of the screen for your 60%, the very small thin air gap for the air means that you're getting much more higher concentration of oxygen than there is air mix, and that's how you get the appropriate oxygen levels. Again, to connect these is just to a normal face mask, and the oxygen tube being your clear or your green tubing, depending as to which your hospital trust uses. But again, it also means that it's a very quick visual clue. If you know your colours, you know precisely what they're on. And again, often it's worthwhile having several to hand if you're treating a patient. But again, you can always chop and change which valve you're using if needed. Again, for people who are on humidified oxygen, be it your tracheostomy patients or patients who prefer these to the Venturi valves, is you're going to have a little dial on top of the humidifier. And what it does, again, same thing as the Venturi valve, but rather than changing the valve, all you need to do is turn the dial around to the appropriate FiO2 that you want to deliver. And again, what it will then do is it will tell you how much recommended literage it needs at the wall in order to get that right collection mix. Okay, so again, depending as to which devices your hospital has, have a look at them. If you've never used it before, put it together, see how it works, so that if in that situation you're there going, I don't know how it works, you can go, actually, I've played with this, I know how to turn the dial, I know what amount of oxygen I'm giving the patient at any one time. So that runs along that particularly is about humidification. And as I mentioned, cold, dry air does increase the amount of heat and fluid loss the patient's getting. And again, the higher amounts of oxygen they're on, often the sicker they are. So actually we need to minimise the failure that we're causing by giving them dry gases. So again, these patients may have difficulty moving secretions, and if we're giving them dry air, it's going to make it even worse. Now the pictures of an aqua pack, this is a cold system hydration, which again doesn't get past the fact that where it's not heated. So again, the patient's still got to work a bit harder to then heat the air that's coming in, but at least it's now got some moisture in it that hopefully keep the secretions a bit looser. Obviously, the best form of hydration for a patient is oral intake. So if they can take in some liquid with you, if they can take a sip of water, and again, keeping that oral hydration up is really much, much better than us trying to give fake hydration through a cold chamber, which is quite hard. So really important to kind of keep them hydrated. And again, you'll know how hydrated they are by looking at their fluid balance charts. So again, it's one of those things you can kind of, in your assessment, see whether have they got adequate hydration systemically, rather than me just trying to put in extra water through their airways. Now, high flow nasal oxygen therapy, it's probably coming up to maybe 10 years old. So I think it's something that was quite new and exciting, because actually it meant that patients who were needing high levels of oxygen could actually tolerate it much better and still be allowed to talk and eat and drink and maintain the comfort levels that we'd like them to be on if they're on nasal specs. But because of their unwellness and need for extra oxygen, we couldn't always achieve prior to this. And so what this can do is it not just titrates the amount of oxygen the patient can receive, but also the flow rate that the gas is delivered at. And again, by being heated, it means that the patient hasn't got to work as hard to get the air warm. By being hydrated as well, again, if the patient's getting lots of flow of oxygen, up to 6 litres a minute, that's an awful lot of air that would need to be working hard at if we couldn't do it. But again, the machine does it all for us. So the chamber is a water chamber that's on a heated plate, so that takes the oxygen from the wall that's piped in before delivering it to the patient through the very comfortable nasal specs. Again, there are different size nasal specs for different faces. So again, it's really important that your patient gets the right size for them. And again, making sure that the oxygen actually is supported around the neck, because again, What you don't want to do is it be pulling on their ears and the nose and giving them a pressure sore. So I'm just going to run through quickly the physiological basis for using high flow. So again, when we're breathing normally, we generate a gas flow of approximately 15 litres a minute. It's usually warmed to about 36 degrees and humidified to about 80% by our upper airway. If the patient's breathing through their mouth, you get about 70% humidification that way. However, the patients we're seeing are now in respiratory distress, and they're causing flow rates of a lot higher, of up to 120 litres a minute, which again causes them to have increased fluid loss and higher metabolic oxygen requirements to achieve these warming gases. So we're making them work harder to get the oxygen in, and it's kind of more like a circle, really. So actually, if we only give them cold, dry gases, this is going to make this heat loss worse. They're going to become more discomforted, and actually they're going to reduce their compliance to actually wearing the oxygen at all. So actually, by giving them high flow, it can actually reduce all these things and be much well tolerated. So features is, I've said, it gives warm humidified gas, and so it comes out around 37 degrees, which is perfect. And by doing this, you're going to reduce their airway surface dehydration, and by doing that, improve their secretion clearance. And in turn, it's going to reduce the amount of atelectasis that you're getting because of secretions. Again, your gas flow can be varied to be a lower flow or a higher flow. And with this, what that's doing actually is causing the ability to have CO2 washout and reduce the amount of dead space between your mouth and your lungs where you're getting your gas exchange. Because what you're doing is, rather than it being full of carbon dioxide, it's going to be full of oxygen. So again, it's providing what we call an oxygen reservoir in the patient themselves. So if they keep their mouth closed, it will become a chamber of oxygen. So actually, they're breathing in, and actually the oxygen's going down a lot further with a lot more ease, a lot less effort. And again, in the same way that we would think about using kind of CPAP to give some level of PEEP, it has been found that in these patients who use high flow nasal oxygen, it can give some element of PEEP. Now, again, it's not exact, and the papers do kind of say it's between 3 and 7 centimetres of water, but you can't be absolute with the amount of PEEP. What, again, that's going to do is it's going to increase your end expiratory lung volumes and, again, improve your alveolar recruitment. So if you have got areas of atelectasis and collapse, you're going to get some recruitment going on that may splint the airways open. Again, and we know splinting of airways will mean that it's much easier to breathe because you're not getting alveolar collapse each time you breathe out. So it's got lots of reasons why it's really, really useful. What can be more difficult to do is in lots of hospitals, it's still restricted to be on your HDUs and your ITUs. And again, it's because the need to kind of maintain these patients, because they aren't going to be ill from a respiratory point of view. They may have other cardiovascular issues going on as well, and actually need much higher supervision than just being left at the bedside as you would do for normal nasal specs. Again, the ease of using the high flow is actually you can increase your oxygen from being quite a down beyond 24% all the way up to 100% and down again, and anywhere in between. You're not restricted to being on certain percentages because the numbers will go. If you want 34%, you can have 34%. If you want 47%, you can have that. You can be really, really precise how the oxygen you're giving, which for some people is really, really good. Now, I spoke a lot about kind of devices. I'm kind of going a bit off topic here, but I think it's really important to be aware of actually your flow meters that are at the wall. Now, what you'll do is you'll look at there'll be at least 2 flow meters on most wards now. One will be oxygen and one will be air. So really, really simply is making sure that you know which one's which. So your air ports should be blocked off. Again, there was an incident several years ago where actually in a crisis, the non-rebreathe bag was attached to the air port by accident. The person was turned on, and unfortunately the person arrested and actually subsequently died. And the investigation showed that actually by having two ports on, the person who put the non-rebreathe bag on didn't know the difference. So from that point forward, all hospitals are meant to remove all their air ports from the wall all the time with a cap on it. But again, you may have some in the wall now for people who need the nebulizers who are running it through air. So do be aware as to when you're looking at your 2 ports, which one's oxygen and which one's air. And with that is knowing how much oxygen am I giving the patient, because you can look at the dial and you can turn it up And do you want to read from the top of the ball, the line, the middle of the ball, or the bottom of the ball? And again, looking at studies, typically physios are better at this, but I'm not saying they're perfect. And again, what you're looking for is looking at the middle of the ball. So where the middle of the ball's floating, that's the level that you're given the reading. So not the top of the ball, which could be up to half a litre more, or bottom of the ball, because that gives you quite a big range of how much oxygen could be delivered and could be the patient receiving. So really important that you get the middle of the ball to do that. And again, going on from that is really looking at kind of your documentation of this. This is taken from the News 2 charts. And so I think most trusts on wards will be using News 2, but I could be wrong. And again, if you're in intensive care or HDU, they may have slightly different. So again, looking at the top scale one, this is where most of your patients are going to be. So again, like Tash said, is you've got your different levels of scoring. So above 96 is nothing, 94 to 95 is 1 point, 92 to 23 is 2 points, and below 91 is 3 points. And that's where most of your patients are going to be. And again, you're looking for trends. Now, on scale 2, these are your patients who've got underlying respiratory disease who have a target saturation of 80 to 92 because they have hypercapnic respiratory failure either currently, as an acute situation, or chronically that we know about from the community. And again, this has 2 variations of scale. One, again, if they're deteriorating, so 86 and below, but also going upwards, because again, what we don't want to do with these patients is actually over-oxygenate them, because this will also make them worse. So again, if you're seeing them going upwards, it's really important that we bring the oxygen down to keep them in their target zone of 88 to 92. And again, if you are recording it, it's making sure that we know, is this saturation being taken on air? Is it on oxygen? And then what the oxygen literage of that, but also the device. So if it's no good putting that they're on 8 litres in the O2 litres a minute box, but you've not said that they're on humidified, because it could be that you're saying they're on a full face mask, they're on a non-rebreathe mask. We don't know what the 8 litres is on. So again, really important that we clarify not just the literage, but the device we're giving it through. And again, really important, like I said at the start, oxygen's a drug, and we don't often think of it as a drug, but it has got a drug chart place. It's on the drug chart and should be signed for. And again, if your patient that you're seeing hasn't got it prescribed, then how are we going to know what we're targeting towards? We will assume they're at the upper end. We don't always know. So making sure that your medic colleagues have prescribed it. And again, on ward rounds and drug rounds, that it needs to be signed for as well. Again, it's more easy on your e-prescribers, because you have to kind of tick to say, yes, you've looked at it and documented it. But on paper charts, it's often the box that's not signed, and it can cause issues later on. But oxygen, when it's used appropriately, is really, really beneficial and can really help lots of patients to get through their acute crisis. But when it's misused or abused, it can really, really be potentially harmful. I hope that hasn't scared you, because oxygen's really, really good and it's a really excellent treatment for our patients. So thank you very much for listening.
Thanks so much, Jane. That was so comprehensive. There is so much in the chat. I don't even know where to start, and I'm conscious of time. So I am going to continue to answer some of the questions in the chat, and I'm sure, Jane, you can assist me.
Yeah.
Just there is a few comments about the use of non-rebreathe mask. Now, obviously, Jane's covered in normal. So when you're saying what we would class as normal respiratory patients, and then we have pandemic, and we are seeing patients being kept on what would be classed as an emergency oxygen device, 15 litres via a non-rebreathe bag. And the reason why it is typically at 15 litres, so it gives you enough flow so the patient can get rid of their exhaled gas through what is essentially a mask.
And again, it's obviously kind of, it can be used sometimes as a holding device, because again, these patients may either be for escalation, in which case they need to move to a area that can give them their NIV, their CPAP, their ITU for interventilation. But actually, for some patients, it can be the ceiling of their care. And actually, in order to keep them comfortable until the end, actually the amount of flow that's needed is the non-rebreathe. So actually, it's ideally only used for emergencies, but again, during the pandemic, it is being seen in lots of patients, and often more in areas where aren't used to experiencing these patients who are so sick.
Yeah, and when we refer to Optiflow, then yes, it is a form of high flow nasal oxygen therapy. And obviously that is a whole presentation in itself. But the thing about COVID, which is unusual or is kind of unique to this respiratory virus as other respiratory viruses is that patients can require a high amount of intravenous oxygen therapy to hold them. And what we normally see is when patients are on higher levels of oxygen therapy and then fatigue, they maybe more quickly develop what we call type 2 respiratory failure, hypercapnic respiratory failure. But actually some patients, and this is what we're seeing in this wave of the pandemic in the UK, is we're seeing a lot of patients not moving to critical care units. We're treating them in respiratory medical wards, in respiratory support units with CPAP, high flow nasal oxygen therapy, or with what is high levels of oxygen therapy. And then it's understanding your oxygen supply, it's understanding target saturations, it's understanding if your patient has a long-term underlying respiratory condition where they might need lower oxygen levels. So having the time to do an individual assessment and go through all of that is really important. In pandemic times it is difficult, but this is why the more people that know the basics and what different types of oxygen systems can deliver, I think is really important. And so for that reason, Jane, I'm really grateful you've done this session.
That's right. I suppose the other thing is obviously when you're on about oxygen supply, so many people won't be aware that oxygen in a hospital comes as liquid oxygen and is stored in great big tanks outside. Now, in normal times, the hospitals have absolutely enough oxygen for every single patient because they're usually on quite a small amounts, and not every patient is on oxygen. During the pandemic, there's obviously been lots of people on high levels of oxygen and high flows of oxygen that really has impact upon the logistics and the estate facilities that actually maintain the amount of oxygen getting into the hospital. And so lots of hospitals have to either increase their supplies dramatically or the deliveries. But again, if you are on wards and patients don't need their oxygen, then actually making sure that it is turned off at the wall, because even the few litres that may be turned off is really, really important for the whole service to maintain stability and safety.
Absolutely. And on that note, I'm going to say thanks so much to Tash and Jane. Absolutely amazing. We've got 10 minutes before the next speakers, everyone. So go and stand up, stretch your legs, go and get a drink, and we will start again at 11:30. Then you are going to have a full half hour for lunch. So just keep the live stream open.